This has been a fantastic year for adjuvant treatment of melanoma. We have two outstanding abstracts that are presented with extremely positive studies, one that is not positive. We have seen in the metastatic setting that targeting both BRAF and MEK is highly effective. And of course, this was a natural question to see whether this would improve also survival in the patient in the adjuvant setting.
Adjuvant treatment of malignant melanoma for high-risk patients is still a challenge. So there's a high unmet medical need. We were waiting for something which is a breakthrough, showing us new results. We were aiming on 40% of the melanoma patients, namely those with a BRAF V600 mutation. The study design was as followed, a very clear study design. It was dabrafenib, a BRAF inhibitor, plus trametinib, a MEK inhibitor. And this was one-to-one randomized, in a double-blinded fashion. And the primary endpoint of the clinical trial was relapse-free survival. The primary endpoint, as I mentioned before, was relapse-free survival. We showed a hazard ratio of 0.47, which is a risk reduction of 53% for relapse-free survival, a very remarkable result. This is the best hazard ratio in a placebo-controlled trial which has ever been shown in the adjuvant treatment of melanoma. And furthermore, we could demonstrate 3-year relapse-free survival rates, so landmark analysis, and also the overall survival data corresponding to this. And in long-term survival, you see a benefit for dabrafenib and trametinib. The hazard ratio for overall survival was 0.57, which is a very good result and even exceeding my personal expectations. Toxicities were exactly the same as being seen in stage 4 melanoma setting, which means the drug has already been approved, this combination for stage 4. No new toxicities, 41% grade 3/4 toxicities, but a little more treatment discontinuations, 26% in this adjuvant trial. This may be caused by 1 year of treatment for patients who are currently disease-free. Maybe the pressure on the patient is not the same as in the metastatic setting, but this is pure speculation.
Here we have seen a hazard ratio for relapse-free survival of 0.47, which is probably the most important and dramatic difference we've ever seen in the adjuvant setting in melanoma. So clearly this sets BRAF MEK inhibition as a new, very firm option for our patients. Since last year's ESMO, we know that ipilimumab 10 mg per kilo provides overall survival benefit in stage 3 adjuvant setting. The problem is this drug is highly toxic, and so we really needed to have an alternative. And this study has tried to compare Nivulomab to ipilimumab.
A major unmet need in the field of melanoma is the fact that patients with resected high-risk melanoma, and by resected high risk, we're talking about stage 3B, 3C, and resected stage 4 melanoma patients, have at least a 50% risk of relapsing at 5 years and a 50% risk of death at 10 years. And that provoked the performance of a randomized phase 3 blinded trial. This was an adjuvant trial which compared the use of 1 year of Nivulomab, the PD-1 blocking antibody, to ipilimumab, the CTLA-4 blocking antibody, again for 1 year. And the results of that trial, which was stopped at an interim analysis, which is usually a good sign in a phase 3 study, it means it was a positive study. And indeed, this was a very positive study with a primary endpoint of relapse-free survival over time. The results of this trial showed that there was a clear benefit to receiving Nivulomab compared to receiving ipilimumab with respect to the endpoint of relapse-free survival. The hazard ratio for benefit for Nivulomab compared to ipilimumab was 0.65, which of course translates to a 35% reduction in the risk of relapse over time. The p-value for the difference was an impressive 0.0001. So again, clear-cut benefit, both clinically significant and statistically significant. There was a 66% 18-month survival versus a 53% 18-month relapse-free survival. So again, that relapse-free survival actually looked like it was opening up over time, comparing 12 months to 18 months. So in every respect, clear benefit for receiving Nivulomab adjuvant therapy compared to ipilimumab. Not only was it more clinically effective, but Nivulomab was less toxic. So whichever way you assess it, it looks like adjuvant nivolumab therapy for high-risk resected melanoma is superior in every way to ipilimumab.
Clearly, nivolumab delivers a hazard ratio of 0.65 over ipilimumab that was already better than placebo. So clearly, we have a highly effective treatment, which is in addition much less toxic. So it's clear for us that this is going to replace ipilimumab in the adjuvant setting. BRAF has addressed a very legitimate question, seeing the impact of single-agent BRAF inhibition in the metastatic to try to see what this would bring in the adjuvant. This was a well-conducted study that really tested vemurafenib against placebo.
The BRAF study was a randomized placebo-controlled study of single-agent vemurafenib versus placebo. It was a two-cohort study. The first cohort consisted of patients with stage 2C to III B disease, and cohort 2 consisted of patients exclusively with stage 3C disease. Randomized 1-to-1 to placebo or vemurafenib 960 milligrams twice daily for 1 year of therapy. In the analysis of cohort 2, there was an improvement in median disease-free survival for those who received vemurafenib versus those who did not, but it was not statistically significant. What is interesting, though, is if you look at the disease-free survival curves, there's a striking difference between those who receive vemurafenib at 1 year in terms of their disease-free survival versus those who receive placebo, about 20% absolute improvement. 80% of the patients on vemurafenib without disease progression versus about 60% on placebo. But when drug was stopped at 1 year, over the next 12 months, those curves come together and the results were not statistically significant. In cohort 1, it showed a 46% improvement in disease-free survival for those who received vemurafenib compared to those who received placebo. And the p-value was less than 0.05, but because of the hierarchical statistical design, that can only be descriptive and not statistically significant.
When BRAF was initiated, we had less evidence that dual inhibition with BRAF/MEK was so superior to single agent. Since then, we have realized that. We know that patients derive much longer benefit. And to some extent, it's not such a surprise that it's more difficult to get this very large benefit with just BRAF inhibition. So probably the study has suffered from that, and it's pretty clear that in the future, single-agent BRAF inhibition will not be our choice for adjuvant therapy of melanoma.